right, well, it is 1 p.m., so I'm going to go ahead and get us started today. Thank you to everybody who's joined us so far. I just want to let everyone know at the top that we are recording this webinar and we will post it online for our practices to access later this week. So please be aware of that. I want to thank you for joining us for this webinar on telehealth, virtual check-ins, and eVisits. My name is Carissa Miller. I'm the Program and Communication Specialist for Montgomery County Medical Society. I do have a few housekeeping items before we begin. We've muted all participants at the beginning of this call for sound quality purposes. To unmute yourself, you can press *6, but we do ask that you remain on mute until we reach the Q&A portion. We welcome your questions. The way we'll run our Q&A today is we'll do pre-submitted questions first, followed by questions submitted through the chat box, and then finally audio questions at the end. So today's program will provide a telehealth billing and coding update on how to manage denials and to assist your practice in successfully getting paid by health insurers during this difficult time. With the expansion of third-party payment for telehealth and the changing requirements of payors, best practices are more important now than ever before. But before we get rolling today, I'd like to recognize Ron Kendall from MedCai Insurance Agency, who's one of our Physician Connect partners. Ron, are you here with us?
I am, Carissa. Thank you. I just want to say hi to everyone and hope everyone is staying safe and doing well. And just to thank all the healthcare providers who are keeping us safe during the pandemic. MedCai Insurance Agency is a strategic partner of Montgomery County Medical Society, and we're the only insurance brokerage that returns our net profits back to MedCai. I just want to let everyone know that we are working all remote at MedCai Insurance Agency, helping to provide service to our clients. I've also been emailing MedCai COVID-19 updates to our clients. These updates provide a lot of the information regarding the pandemic with guidance and navigating the various programs that are available to medical practices. And I'm available to assist with any questions that come up. Just want to mention a few good things that are going on in the insurance industry now. For the physicians who use Medical Mutual for their malpractice insurance, you may be aware that there was a recently announced 25% pandemic credit that will be applied to your third quarter billing cycle. So that's a good thing coming from Medical Mutual. You also may have heard a lot of the auto insurance companies are returning premiums due to driving lower mileage during the pandemic. So that's been a good thing. And a lot of our business insurance companies are working with our insureds to defer payments and waive late fees. So if your practice is incurring a financial hardship and you have some issues with making your insurance payments, please contact either us or your broker to just discuss ways of maybe deferring payments or various things that we can be assistance with. Finally, as we're hopefully nearing a transition to reopen practices, I think it's a good time maybe to do a little housekeeping with reviewing the current insurance policies that your your practice has. There's a few items I'd like to point out for a few policies that we offer that you may have in place or you may not have in place, but may want to take a look at. So it's always a good time when you have some extra time to review these policies. I'd like to point out a policy we offer called Employment Practice Liability Insurance. It's something that I know half of our practices still don't have. We do promote it. We try to sell it to our practices. And opening back up the practice right now, it's important that you take a look at something like this, because what it does, it gives you third-party coverage for patients as well as your employees and contractors. And reopening, you could be faced with complaints from employees or patients, for your office not providing a safe environment for work or patient care. So the policy would respond to something like that. If you've had to lay off employees, contractors, or even physicians due to budget constraints, The policy provides wrongful termination coverage in the event that you have an accusation against the practice for that. The cyber insurance policy that we sell to our clients, you could be seeing an uptick in phishing schemes when you reopen, just rogue people getting and trying to hack into your system, looking to provide financial relief services that an employee could click on, and all of a sudden you have a breach. And also just to provide that extra protection, as you may have more employees that are working remote, even upon reopening your offices. Workers' compensation, which I'm sure every practice has, I would just make sure it's updated. If you've had to reduce payroll due to COVID-19 budget, you may want to check with your broker to make sure that they're aware that your payroll has been reduced, which could help lower your workers' compensation premiums. And also just make sure it's enforced, that you paid your bill in case when your employees come back to work and someone is diagnosed with COVID-19, that and they feel like they got it in the workplace, that your policy is enforced and ready to respond. Also, just to review your life and disability insurance policies. We have a new employee that was just hired, John Jacobs. He has over 23 years of experience in the insurance industry and can always provide reviews of your life and disability insurance. So our office is available to provide these insurance reviews, either by Zoom meetings, emails, over the phone, whatever works for our clients. So, take advantage of this time to maybe get a review of your insurance policy. You can always reach me by email or phone, or you can go onto our website at www.medcayagency.com and reach out to us. We'd be happy to provide our services to you. So thanks, Carissa, for having us today.
Thank you for being here with us. I know that we'll talk more about insurance coverage in an upcoming webinar, but I know that a lot of practices are looking at their policies right now. So all of our participants, I hope that you'll keep Ron and MedCai Insurance Agency in mind as you're looking at your policies and considering a review. So we're going to go ahead and begin our program now. I'd like to introduce you to our speakers. We're very fortunate to be joined today by Julia Konovalov and Kate Gilman, CPC of Medical Business Partners, for the presentation. So I'm going to go ahead and turn the screen over to them and we'll get started with our webinar.
Okay, I'm going to share my screen. And all right, so welcome everyone. Thank you so much for joining us for this webinar, and a huge thank you for MCMS for having us. We have been obsessed with this information and trying to figure out the latest guidelines on everything, so we hope you will find this really useful. Let's see. So as some of you may know, I am Julia Konovalov, and Kate Gilman is here with me. She's my business partner, and she is an AAPC certified coder. We own Medical Business Partners, which is a medical consulting company where our main focus is to increase revenues and coding compliance for healthcare providers. But today I know you're here to learn more about telehealth, so not to waste any time, I'm going to get started. Like I mentioned, since the beginning of COVID-19, we have been literally fanatical about everything there is to learn about the latest changes to telehealth. And we are very excited to share this information with you today and hope that you will find it useful. After the presentation, Kate is going to host the Q&A session. So our goal for this presentation is to simplify all the information thus far so that the providers and their billing team know exactly what is covered and how to properly bill for their services so that they can keep bringing in cash flow. Most payers have definitely deregulated their guidelines towards virtual patient care. And there are three main types of virtual patient care, which are telehealth, virtual check-ins, and eVisits. If the patient encounter is due to possible COVID-19, then their financial responsibility will be waived and the payers are paying in full. If the patient encounter is not due to COVID-19, patient may be responsible for their co-pays, coinsurance, or deductibles. All right, so most payers have also relaxed their state boundary requirements. So if your patient is located in a different state, only during this PHE time, you may be able to provide telehealth services to them. There are some specific guidelines about it, and it's always good to double check with your state license requirements, but they are definitely trying to make it easier for both providers and patients. The virtual care can be delivered from home, meaning that your patient can stay in their house and the provider can provide telehealth from their home as well. This has never been permitted before, so this is very unique to this COVID-19 time. When billing E&M codes for telehealth, you can base your level on either medical decision-making or time. The time guidelines have actually changed slightly, and we're going to be going over all this information in more detail. Again, if this is implemented properly during this time, virtual care can be extremely helpful for your patients and generate cash flow for your practice. Now, just this is a reminder, and I'm going to go through this several times during the presentation, but the information is changing rapidly. So it's critical that your staff are monitoring all the updates at least several times each week. This is a checklist that we put together for telehealth. Ideally, this is done prior to starting telehealth. If you've already been providing telehealth services, no problem. Just kind of make sure that you have covered all this information. So for the malpractice insurance, just double check that they're going to be covering your telehealth and eVisits. I believe actually during the pandemic, a lot of them, even if they don't cover it, are making an exception, but you do want to double check that. The virtual services need to be patient initiated or requested. That is a requirement. However, you are allowed for you or your staff member to educate the patients about their virtual options and explain how the services will be rendered. If the patient is fine with the virtual care, please obtain their consent, which can be done by an office staff member. It is valid for up to 1 year. With the commercial payers, it's always better to be on the more cautious side and check patients' benefits for telehealth and virtual visits. Don't assume that, anything is across the board. Be sure to document all your virtual interactions with your patients thoroughly. We'll discuss this a little bit in more detail. It is best to always use HIPAA-compliant platforms if possible, even though during this time they've relaxed this requirement as well. So during the presentation, we're going to be using primarily these three terms: telehealth or telemedicine, which is audio and video live devices, and they can be FaceTime, Zoom, or other telehealth platforms. Virtual check-ins are audio only. So it's literally just talking on the phone with the patient without any video, just as a basic telephone call. E-visits are done through patient portals, HIPAA-compliant email, or HIPAA-compliant text, and they're obviously not performed live. So let's go into some of the documentation requirements for telehealth. The key elements you want to make sure that you include in your notes are telehealth modality. What does that mean? It's just the platform that you used, such as the iPhone, Zoom, etc. Location of the patient. You do want to mention that the patient was at their home, for example. Location of the provider, such as their home or office. Patient consent. Please document that the patient gave consent for the virtual care. Names of any other people present during the virtual visit. It can be a parent, a spouse, a caretaker, literally present during the video chat with the patient, not just present in the house. Everything that was discussed and observed, that's really important. You want to document all that information during the call. Thorough documentation and details is always best practice. You want to document your plan of care, treatment, and any prescriptions if that's applicable. And I'm going to go into this in a little bit, but in some situations, you do want to document time spent and duration, especially if you're going to be billing by it. So I'll give you guys an example of a possible way to document this, because I know it can seem like a lot of items and be overwhelming, but it doesn't have to be. And it literally can be a few sentences that you make a template, and it's just on all your telehealth visits. So for example, due to COVID-19 pandemic and CDC safety guidelines, the in-person visit was converted to telehealth visit using FaceTime via patient's iPhone. The patient verbally consented to the video, and you can document the staff member who took the consent. The patient was located at home, and their spouse, parent, or nurse were present at the time of the call, or if nobody was present, you can just say the patient was located at home. Dr. Smith is located in the office. During the visit, ABC was discussed with the patient. Dr. Smith observed XYZ and recommended or prescribed X. The duration of the call was 20 minutes. Again, that's if you're going to be coding by time. If not, then you do not have to specify the time spent. So with that, I'm going to jump into the CMS updated requirements for time. Don't worry about writing everything down. We will send a copy of this to MCMS so you can get all this information. But as you can see, CMS has slightly increased the time requirements for telehealth versus in-person E&M. The medical decision-making requirements have stayed the same. So for the new patients, there's like a slight difference. You can see a bigger difference for established patients, for example. Okay, for the virtual check-ins, there are a couple requirements. So the phone-only, audio-only calls cannot be related to a visit, whether it was in person or virtual, that occurred within the past 7 days. And it cannot trigger a visit, whether in person or virtual, during the next 24 hours or the soonest available appointment. So here's an example when you can bill for a virtual check-in. Patient called requesting a refill of their medication. Provider reviewed how they are doing on their medication, if there are any side effects. Provider asked the patient if any other medications have changed since the last visit. Prescription was sent to the patient's pharmacy. Total time spent was 10 minutes. That's one example. Another one, when you cannot bill for a virtual check-in, so do not bill if this is the case. A patient was seen in the office and had lab work done 3 days ago. The doctor calls the patient to go over lab results. This cannot be billed to the insurance, as it is continuation of visit from 3 days ago. E-visit requirements. So it can only be billed once every 7 days. So you bill one code for a 7-day period, and you add up all the time spent during that virtual communication, and you bill to the highest level possible. So the entire time from you reading the patient's email or something that they sent you over the patient portal to you responding back and forth, you take the cumulative time of all of that during that 7-day period and you bill, and it's based on time. And with that, let's get started with the payers. So the first one that we're going to go into is Medicare and Medicare Advantage plans. You will see that for the payers, we have last updated information. That is not when we last updated the slides, it's when the last update was provided by the payer. So for Medicare, it was actually very recent. It was May 1st. Sorry. So Medicare, as most of you probably know, does allow telehealth, and they will allow you to bill it with the location of where the services would have been done if this was an in-person visit. So initially Medicare allowed telehealth, but they wanted everything billed with place of service 02. they changed that. So now you can bill for both new and established patient visits, so 99201 through 99205 and 99211 through 99215, and the place of service can be 11 if that's where you would normally treat your patients, as in your office, even if the patient and the provider are both located in their own homes. You do need modifier 95 because that will signal to Medicare that this was a virtual visit. However, they are reimbursing it at the same rate as in person. Excuse me. You do want to append a new modifier, CS, if it's for evaluation of COVID-19 services, and Medicare will pay at 100%. So if it's for a patient that potentially has the coronavirus, you put this modifier, you add it to the claim, and Medicare will pay in full. Also, this is recent. They have allowed for providers to bill 99211 for COVID-19 specimen collection instead of the G2023 code. It can be billed as incident 2 by clinical staff as well. Now, just a disclaimer, this is from CMS, and most Medicare Advantage plans do follow CMS guidelines as closely as possible. However, with all the changes taking place, some might still be behind in using place of service 02. So definitely double check all your denials if you're getting them, and you might need to double check their websites just to see if they're able to keep up with all the changes going on. Medicare is also allowing virtual check-ins. That's the audio-only calls. Initially, it was only G2010 and G2012 codes. They're very low reimbursement. I think it's like $13. Then they added the 99441 through 99443 codes, which were a little bit better. And just starting May 1st, they said that they will be reimbursing 99441 through 99443 at the same pay rate as 99212 and 99214. So this is huge. You will literally be getting paid for audio only the same as for a telehealth visit. However, I do need to caution you, this is such a new update that it looks like on Novitas' website, they are not up to date with it. So monitor your denials, and we're going to speak about denials a little bit later. But if you are not getting paid at the same rate, you might want to put those claims aside and then probably resubmit them, because they're trying to get their system up to date with all the information going on. This is billed also with place of service 11, where you would normally see the patient, and you do not need a modifier, as these codes already signal that this is a virtual call. Medicare is allowing you to do this for new and established patients. And if you're a qualified non-MD healthcare provider, you can use codes 98966 through 98968. However, at this point, there is no information that the 98966 through 98968 will be paid at the same rate as the 99212 through 99214. I believe they're still being paid at a lower rate. Medicare is also allowing eVisits. That's when you're communicating with your patient via patient portal or some kind of a HIPAA secure email or text messaging system. So physicians can bill 99421 through 99423, and it is based on time. So the cumulative time during that 7-day period that it took you to read all the notifications your patient sent you, respond to them. If you needed to research anything, contact somebody else, you put that in, and then you bill to the highest level possible. The place of service is 11. You do not need a modifier. However, this is for established patients only. You cannot bill this for new patients. Now, another really cool thing happened with CMS, and this is just during this time that they are even allowing this kind of services to be rendered via telehealth. Medicare has over 244 codes that have been approved for telehealth. And as of April 30th, 91 of those codes require audio only, which is incredible, because before almost none of them would pay you for it. So you would use the place of service exactly the same as where they would have been furnished if they were done in person, and use modifier 95 to signal that it was virtual. So here are a few examples. If this was a home visit, you would use place of service 12. If this would have been emergency department visit, place of service 23, even if the provider was at home during this time. Some other codes that they're allowing: psych evals, they're allowing medical nutritional counseling, they're allowing prolonged visit code, smoking cessation, blood pressure, patient education and training, TCM, advanced care planning, diabetes management, annual wellness exams are allowed, depression screening, prolonged preventative services, and much, much more. Obviously, we were not going to include the list of 244 of them here. If you need it, just send us an email and we'll send you the spreadsheet of all the codes. But there are a lot of services that can be provided virtually now. Next, we're going to look into Maryland Medicaid and Medicaid MCO plans. So Medicaid at this point allows only established patients to be serviced via telehealth, and you would use 99211 through 99215. The place of service is like Medicare, so it is where the encounter would normally take place. So if it's in the office, it'd be place of service 11. The modifier that Medicaid wants is GT. So Medicare wanted 95, Medicaid wants GT, and they're also allowing virtual check-ins. They are only using 3 codes, and to the state, they are the only payer that is using E&M codes to bill for virtual check-ins. And they're allowing 99211 through 99213. Place of service where they normally would take place. So if it's in the office, it's 11. The modifier is UB, and it is also for established patients only. They are not allowing any eVisits at this time, so you cannot bill for those services. And a couple more things about Medicaid. So if this was the original Medicare crossover claim and you use place of service 02, which is what you needed to do in March and even beginning of April, they said that's fine. You do not need to resubmit anything. They will process those crossover claims. They highly emphasize that if it's at all possible, you should use the traditional telehealth technology and for it to meet the highest level of HIPAA compliance. However, if that's not possible, you do need to document it and put that in your notes that, you know, either the patient didn't have that kind of platform available to them or you don't during this COVID-19 time, and they will still be able to pay for your services. And lastly, they will be monitoring the use of audio-only telephone services. They don't want this to be the time when providers are expanding their services, so they will be monitoring for volume, and all outliers will be audited. With that, let's go into Aetna. So Aetna actually had quite a few changes. Originally, they allowed telehealth billed with the normal place of service, where you would normally take place. However, mid-April, they changed it. So they are allowing it for new and established patients, 99201 through 99205 and 99211 through 99215. The place of service Aetna now accepts is only 02. For Aetna Medicare, you may use place of service 02 or 11 because they're following CMS guidelines, so they have to accept 11. But for commercial, it's 02. The modifier they accept is 95 or GT. So either one of those is fine. They are also allowing virtual check-ins. You can use the G codes or the 99441 through 99443. Just like with telehealth, the place of service is 02. No modifier necessary for these codes, but it is for established patients only. The non-MD healthcare providers can use the 98966 through 98968 codes. Aetna originally was allowing the eVisits. However, mid-April, April 17th, they changed their policy and are no longer covering those unless they're state mandated. This temporary order is going to be re-examined on June 4th, where Aetna will see what's going on with the pandemic, and if necessary, will either adjust their policy or, have it go for a little bit longer. With that, let's go into Anthem Blue Cross Blue Shield of Virginia. So they are permitting telehealth. They're also allowing the new and established patient E&M codes. Like Aetna, they are only accepting place of service O2. The modifier is 95 or GT. You can use either one. For audio-only calls, they are normally not covered, and Anthem stresses this very strongly, that they are allowing it, but it is for a very small time. So it's from March 19th for the next 90 days. They do not allow the G codes, but they are accepting 99441 through 99443. Place of service, again, is only O2. No modifier necessary, and it is for established patients only. And they're also accepting the qualified non-MD healthcare provider codes. At this time, they do not allow eVisits. CareFirst is our next plan, and they're very similar to Anthem. So they are allowing telehealth, and it can be billed for new and established patient E&M codes. Place of service, again, is O2. The modifier can be 95 or GT. They are actually also allowing office consults. So you can bill 99241 through 99245. Place of service, again, O2, modifier 95 or GT. However, these are for established patients only. You cannot bill this for new patients. Virtual check-ins, there has been a ton of confusion with it, and we've received a lot of calls. So first of all, CareFirst only covers one code, 99441. They reimburse $20 flat fee, period. Some providers have received a little bit more if it's part of their PCMH program and they just get paid higher. But otherwise, it's a $20 flat fee, regardless of how much time you spend on the phone with the patient. Place of service is O2, modifier 95 or GT, established patients only. And the key with their audio-only calls is the only providers who can bill for it are PCPs, OBGYNs, family practice, and pediatrics. These four are the only ones who will get reimbursed for it. So if you are a provider who has dual specialties, you're a primary care and also a specialist, depending on the patient who you will be seeing, if you will be seeing this patient as a specialist, CareFirst is not going to reimburse you, even though you're also a primary care provider. At this point, CareFirst is not paying for any eVisits. Next is Cigna. Cigna is allowing telehealth, and it is billed with the location of where the services would normally be furnished. The office visit CPT codes are 99201 through 99205 and 99211 through 99215. They are currently accepting 3 different modifiers. All are fine. Initially, it was only GQ, but now they're accepting GT or 95. They are accepting one consult code, 99241. Place of service 11. No modifier is necessary, and it is for new and established patients. It can be billed. Virtual check-ins, they only accept one code. It's G2012. Place of service is 11. You do not need a modifier with it, and it is for established patients only. And at this time, they do not allow eVisits. This temporary order will be re-examined May 31st. Any service that is currently on the provider's fee schedule potentially could be provided virtually. That is on Cigna's website. So they're saying anything that is appropriate. Obviously, you can't do procedures or surgeries, but if it is something that's appropriate and it's on your fee schedule, that they will be covering it. On their website, it also says that while they reimburse consistent with the face-to-face rate, they will be monitoring level 4 and 5. If you are only billing those codes, there's a very good chance that you will be audited. Next is Johns Hopkins EHP. So they are reimbursing for telehealth for new and established patient E&M services. The place of service they accept is O2. They accept all 3 modifiers, 95, GQ, or GT. There is no restriction on place of service of rendered services. However, the same authorization requirements apply for telemedicine as they do for face-to-face. So if you typically need to get prior auth for your patients to be seen, you will need the same for telehealth. For virtual check-ins, they do not accept the G codes, but they are accepting 99441 through 99443. Place of service is 11, and the 3 modifiers, 95, GQ, or GT, are appropriate, and it is for established patients only. You cannot bill it for new patients. They are also accepting all the eVisit codes, so physicians and non-physicians can bill for this. The place of service is where services would normally be rendered, so 11 if it's in the office. Modifiers 95, GQ, or GT need to be appended to the claim, and it is for established patients only. Humana is next. Humana is allowing telehealth. It is for new and established patients, and in the place of service is where the services would normally be rendered. The modifier is 95. They are also allowing office consults. They are the only ones at this point who are allowing it for new and established patients. The place of service is 11, modifier 95 again. They're also allowing all the codes for virtual check-ins. So you can do the 2G codes or the 99441 through 99443. Place of service is 11, modifier 95, and it's for established patients only. So the phone only is for established. The telehealth can be for new and established. Humana is also permitting all eVisit codes for physicians and non-physicians. Place of service is 11, modifier 95, and it is for established patients only. With that, our last payer is United Healthcare. So United Healthcare is allowing telehealth for new and established patients. The place of service would be where the services are normally furnished. So if it's in the office, it would be 11, modifier 95. They're also allowing virtual check-ins. Initially, it was only G codes. However, they recently added the 99441 through 99443. Place of service 11, modifier is not necessary, and they are allowing it for new and established patients. They're allowing all the codes for eVisits for physicians and non-physicians. Place of service, again, 11 if it's done in the office typically. The modifier is not necessary, and it is for established patients only. So their temporary order is set to be re-examined on June 18th, and then they will decide how they want to go forward with it. So in conclusion, make sure that your staff are checking all the payers' websites at least once every week. What was allowed last week can be different this week. Pay really close attention to all your denials for any virtual care. For example, it could be due to the payer's internal software not being up to date with all the changes taking place. Things are happening so rapidly that we've noticed some payers put out new guidelines for billing and coding while their software is still trying to be updated. So you may need to just resubmit those claims. New updates are constantly happening. So if you were getting paid previously and now you're not, it's really important that you find out why, because maybe some changes took place. Just like we discussed with Aetna, for example, Aetna initially paid for place of service 11, now they only pay for place of service 02. As I mentioned with CareFirst, your denial could be specialty specific. So if you have more than one specialty, this could affect potentially how you're getting paid. It's really important that you find out so that at least you know exactly how different payers, what they're allowing and what they're not allowing. The example that comes to mind is you are an internal medicine doctor and you are also an endocrinologist, and you see some patients as a primary care provider and some as a specialist. This Blue Cross Blue Shield member has an HMO plan. They have a different primary care provider. They come to see you as a specialist. CareFirst will not be paying you for the audio-only calls if you were to do them, even though you are listed with CareFirst as both specialties. And it could be denied for any other reasons. Just make sure that your staff really understand the denial and inform all the providers of any changes that they've learned. You want to be as proactive as possible so you're not just being reactive with your billing. And lastly, this is a really great time to reach out to your patients and educate them on all the virtual care your practice is providing at this time. Let them know the best way to get in touch with your providers. I'm going to give you a list of what we think are some of the ways that you can maximize your cash flow during the COVID-19. So the first is obviously provide telehealth, virtual check-ins, and eVisits when possible. This has been severely deregulated, and there's a lot more that you're allowed to do at this time. Take advantage of it. If necessary, open your office for some acute and emergency appointments. This is a great time for your staff to follow up on all outstanding insurance accounts receivable. This can be a very significant amount of cash flow for your patients. You want to make sure that you're sending out patient statements regularly and that your staff calls patients with a high balance. We're finding out that quite a few patients are willing to pay balances that they've ignored in the past, and it's definitely a lot easier to reach them on the phone right now. Another thing you might want to do is develop a marketing strategy for after COVID-19. It can be such as updating your website, or maybe reaching out to your patients who are satisfied with your practice and asking them for a review. Reviews are playing a huge part in attracting new patients and potentially renegotiating your contracts with the insurance companies, so don't ignore them. And lastly, make sure you're taking advantage of all the grants and forgivable loans out there. There are several federal and state-specific grants that can be extremely helpful right now. And the last slide I wanted to show you is some telehealth grants and promotions that are right here in Maryland, in case you're not aware of them. So there is the Maryland Healthcare Commission, which is offering $500 for a telehealth grant to practices who have not yet billed for telehealth. So if you've been on the fence about offering telehealth, this can be a great opportunity for you to receive this grant. CareFirst is offering a HIPAA-compliant telehealth platform. I believe it's for free for practices with 5 or less members who enroll for the first time after March 1st of this year. I think it's free for probably the duration of this year. Also, CareFirst is offering iPrescribe for the first year for free. It allows you to electronically prescribe medication, and their app is available on your phone, and it is connected to CRISP and PDMP. So you can access that information directly from your phone, and it can be really helpful, especially if you're working remotely. And MCMS has a comprehensive list on their website of many telehealth vendors. So I definitely encourage you to visit it and check out different platforms that are available. Some are free, some might have a nominal fee, but they are all HIPAA compliant. So definitely visit the MedCai and MCMS websites for additional details and resources. And this wraps up our presentation. We're going to open up the Q&A. Definitely submit your questions in chat if you haven't done so already, and we will try to answer as many as we can.
All right, great. Thank you so much, Julia. So I will get us started with pre-submitted questions. And the one at the top of that list is, what documentation is needed to bill an audio phone call to the various payers?
So this is actually a part of this presentation, and what we would recommend to do once you will receive it, let me just get this slide pulled up. So you would need to make sure that in the software that you're using, if there's an option to create like a small paragraph that would disclose information that this was in fact a telehealth visit. So you would need to include the telehealth modality, the location of the patient, location of provider, consent of the patient, names of any people who are present. It's especially important for if the patient is a minor, and everything that was discussed and observed. So basically, if it's a video call, treat it as it was an in-person visit. So anything that you would discuss, however you would document with the patient, that's what you would consider proper documentation for the visit. If this is a telephone call, then you would just indicate exactly that. You would still need to indicate that which modality you use, where the patient was located, where the provider was, that the patient provided you with the consent for the call, if anyone was present during the call, and then what exactly was discussed. And then for telephone calls, we would advise to document the time, because basically that's what payers want. You can bill based on the time spent with the patient.
Okay, great. So our first question from the chat is, if a patient is in a nursing home, which POS should be used?
So if this is a Medicare patient, you would bill the location where the service would have been performed. So if you usually bill location 33, I believe, 31, 30, I think 31 location is for skilled nursing facility, that would be the place of service that you would bill for. And then of course, if it's 32 for a nursing facility, that's the place of service for a Medicare patient. For other patients, I would definitely look into their insurance benefits, how their carriers would want them, and what they would actually cover. Because, like for instance, CareFirst, they only want place of service O2, and Aetna now only wants place of service O2.
Okay. So this question is with regards to Medicare and Medicare Advantage plans. If a patient encounter is related to COVID-19, does the practice need to add the modifier CS along with the modifier 95, or just leave it at CS as the modifier?
So if it is a telephone call, you would only list CS modifier, because they do not want the modifier 95 on a telephone call. But if it is video visit and you're billing the E&M, use modifier 95 first to indicate that this is a telehealth service, and then modifier CS to show that this was COVID related.
Okay. So if a visit is asynchronous, can it still be considered an eVisit?
So because eVisit is through the portal and it's basically the exchange of messages, yes, that's correct.
Okay. So we have several follow-up questions about billing for physician assistants, specifically asking for Medicare if they would be using 99441 through 43, or do they need to be using other non-physician specific codes? And then sort of the same question when it comes to CareFirst billing.
So I can tell you right now for CareFirst, I can even read to you specifically what they say regarding the visits. They're saying that phone consultations are at this point provided by physicians and nurse practitioners, credentialed in CareFirst network. So they don't indicate the physician's assistant would be covered entities for this service.
Okay.
As far as Medicare is concerned, I believe that they should be able to bill for the phone calls for Medicare. But we can definitely double check that and get back to you if that's okay after the presentation. Maybe this is something that you could send to the person who asked that question.
Sure. And Dr. Baksh, if you are on the line, if you have a follow-up to those questions about billing for PAs, feel free to unmute yourself. To those asking if you can get a copy of the PowerPoint, we will be sending it out via email after the presentation. This question asks, care management calls to patients initiated by a non-physician, such as a medical assistant, can they be billed to Medicare?
So there is a code for Medicare for non-physicians, Let me see. I believe, I apologize. Let me see. So the codes would be the 98966 through 98968. And let me tell you, 98966, I will just give you the definition for them. So it's a telephone assessment and management service provided by a qualified non-physician healthcare professional to an established patient, parent, or guardian not originating from a related assessment and management service provided within the previous 7 days, nor leading to an assessment and management service within the next 24 hours or the soonest available appointment.
Okay. So that's bringing me to the end of questions I see in chat right now. If you are on the phone and you would like to ask a question now, you can press *6 to unmute yourself, and we would be happy to answer your question.
Hi, I have a question regarding if a patient comes in with symptoms of COVID-19 and we test them and send out the test to the lab, and maybe like in 2 days or 3 days we get the results, and can we bill them the 9941 to give them the results?
So technically you're not supposed to, because it's sort of like a continuation of care.
Okay, you're not supposed to. Okay, thank you very much.
Sure.
All right, anyone else? Okay, in that case, I want to thank everyone so much for joining us. We will make a recorded version of this available on our YouTube channel, so please don't forget to subscribe. We'll send that to you in a link in an email. We'll also send the PDF of the presentation, as I had mentioned. And then if you do have individual follow-up questions that we didn't cover that you run across later, please don't hesitate to send them to us, and we're happy to assist you. There are a few things that I wanted to let you know about before we do hop off of this webinar today, and that is that MedChi is continuing to coordinate all clinician calls with the Maryland Department of Health every Monday, Wednesday, and Friday. So if you'd like to register for that, we always have the registration link on the homepage of montgomerymedicine.org, so please visit us there. We will have another webinar in this rapid implementation series next Wednesday, May 13th, and it will address considerations for practice reopening. So that registration will open later today, and we will make sure to include that in the email as well. We hope that you'll set aside time to join us for that. And then finally, I just want to draw your attention to some well-being resources. We had a collegiality conversation with more than 40 local physicians, all on a Zoom call together, having a conversation about their experiences during this time. We have some support follow-up from that, so we'll share that article with you. We also do have the Physicians Resource Network available to us in this county. So that's a program of the National Capital Physicians Foundation, a charitable organization formed by the Medical Society. And they do offer no-cost counseling to physicians, and they are doing televisits. So if that's interesting to you, or you think that someone else in your practice might want to access that resource, or a colleague, we'll include some information about that as well. So I'd just like to say thank you again to our speakers, Kate and Julia. They provide such excellent information to us, and we really couldn't offer educational sessions like this without them. So thank you both so much.
Thank you so much.
Thank you. Thank you for having us. And if anybody has questions after this that you think of or something's not sure based on our presentation, please reach out to us and we will seriously do our best to try to help you and figure it out together because this stuff changes very quickly.
All right. Well, thank you all so much, and I hope you have a
Thank
great
you.
rest of your day.
Okay,
Thank you.
thanks.